Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of speaking with Professor Anna Fagotti from Gemelli Hospital in Rome, Italy. It is always such a pleasure to speak with Anna, and certainly we are very grateful for your accepting our invitation to doing the podcast. Dr. Fagotti was, of course, one of our former associate editors in the journal. We miss her dearly. She made great contributions to the success of this journal, and we're so glad to have you back. Anna, welcome again to the podcast.
Thank you, Pedro. It's always my pleasure to be back. I also miss you and all the community. It was a great time. Thank you for inviting me.
Oh,
again.
Of course, a pleasure. And congratulations on this very important article recently published in the Journal of Clinical Oncology titled Hyperthermic Intraperitoneal Chemotherapy in Platinum-Sensitive Recurrent Ovarian Cancer, a randomized trial on survival evaluation, the HORSE MITO-18 trial. Anna, congratulations on this great work. And of course, obviously, congratulations to all of the co-authors that participated in this important study. So I'm really very excited to talk about this study. And I wanted to just start by first discussing today, who do you consider are the patients that may ultimately benefit from secondary cytoreductive surgery?
So, Pedro, thank you for this question that I think it's very important right now with all the changes that we have in terms of maintenance treatment and all the data that we are receiving, and also the data that we have today about surgery at time of secondary primary recurrence. So if I want to reply to your question, I think that at the end of the story, surgery may have even a higher impact than in the past. This is my conclusion. And the reason is that I made some research in the literature, and I was looking at all the median overall survival from all the studies, analyzing the role of surgery at time of recurrence. And we must say that the results are good, I would say. For those who had a comparable arm in terms of chemotherapy, or for those who had a comparable arm in terms of surgery and HIPEC. But anyway, the median overall survival is more or less the same, and it's quite good. But we have also other considerations to do. The first one is that most of these patients actually today have received some kind of maintenance, and mainly at least 50% of them have received PARP inhibitors. And we have the results from the first line that say that if you have the best results that you may have is when you have complete resection and then chemotherapy and PARP inhibitors. So if we want to replicate this approach, even at the platinum-sensitive recurrence, we may suppose that we may have the best benefit with surgery together with additional treatment. The second point is that from most of the studies, we have seen that the recurrence after PARP inhibitors may be very bad. And we see that some of these patients do not respond to platinum anymore. So there must be like a cross resistance between platinum and PARP inhibitors. So maybe these patients may benefit more because we don't have any other options to give them. Yes, we have the ADC now. We may have the inhibitors of WEE1 to respond to this resistance. But anyway, surgery is an option, especially today, maybe more than in the past. So on this basis, I would say that I would not consider not to offer secondary cytoreductive surgery in patients with a platinum-sensitive recurrence. I think it's too early not to consider surgery for them, although I know that the GOG study was negative. I mean, and also the SOC1 has some problems. I know this, but we may explain the reasons for these negative results. And we don't have any other options, or there are not so many right now. So I think we should still consider surgery.
Excellent. So
for
thank you
this
for
patient.
that great introduction, Anna. And as we get into the topic of HIPEC, and of course, obviously the
Mm.
focus of this study, I wanted to first highlight, of course, obviously those recent data from the group in France and the CHIPOR study that evaluated HIPEC in the setting of secondary surgery. Can you just, for our audience, describe a little bit of the details of that study and how that study might differ from this one?
Yes, this is very important actually, because we had two trials with different results. So I understand that people may be surprised and confused by different results. The main difference was that they included all patients with platinum-sensitive recurrence without considering or screening patients based on their resectability at time of recurrence. So all patients were all included in the trial. They were given chemotherapy, first 3 cycles, then reassessed, and then 3 additional cycles. And only patients considered resectable after 6 cycles of chemotherapy were actually included in the study, and then they were randomized when the complete gross resection or nearly complete gross resection was achieved. In our trial, we followed, we considered only upfront secondary cytoreductive surgery. So only patients who were considered resectable at time of the recurrence, they were included in the study. Again, we had randomization intraoperatively, like the CHIPOR, and patients were randomized when either complete or nearly complete gross resection was achieved. So I think that the main difference is this, and this is a very important difference because actually they were able to test the platinum sensitivity again, whereas we had no option in this regard.
Excellent. So now getting on to this trial, the HORSE trial, and you spoke a little bit about the inclusion criteria already. Now, what were some of your primary and secondary endpoints for this particular study?
So the primary endpoint was the secondary progression-free survival, which was defined as the time from the diagnosis of first platinum-sensitive recurrence to the second recurrence after surgery, HIPEC, and chemotherapy, which was included in this trial. The secondary endpoint was post-recurrent survival and mainly pattern of relapse and also, of course, complications rate and so on. Yeah.
Excellent. So now, can you tell us a little bit about, I believe there was a statement that talked about early closure of the study. And if you can just elaborate on this before we get into the results.
Absolutely, yes. So this was a quite long study because the first patient was enrolled in February 2012, and it took around 7 years to enroll all patients. But then, as you can see, the follow-up was very long. All patients were followed up for a very long time. And I think this is a very particular, a very important characteristics of this trial that I would like to highlight, and I'm happy that I can do here. Because if you look at the results, and this is very important, this trial has the longest ever presented medium progression-free and overall survival. I tried to compare with all other studies, and it's really incredible. So we were checking several times. If you look at the medium progression-free survival, it's actually like double with respect to the other trials with HIPEC, but also double with other trials with surgery at secondary cytoreduction. And the same for median post-recurrent survival, around 100 months, which is really incredible. So it means that we have selected a very special population, and we can discuss this later. But having said that, you can imagine how long was the follow-up in order to achieve the pre-planned number of events that we had to achieve. So at a certain time, it was really an effort to reach out all these patients every time in 10 years, and was extremely expensive also on the other side, you know, having a trial open for such a long time. But we couldn't close the trial without having an independent committee checking all the numbers and demonstrating that there was no value to continue to follow up these patients. And so it took 1 year since we created the committee until they decided to close finally the trial, because they wanted to prolong the follow-up as much as possible. But then, as you can see in the study, we had like a curve with the plateau in the last 2 years. In the last year, we had only one additional event. So at that time, they finally agreed to close the trial. We also made some statistical analysis, moving the remaining patients who were still free of recurrence in one group instead of the other, and the results wouldn't change. So at the end, we were allowed finally to conclude the trial and to offer the results to the community.
Great. I'm really glad that you touched on that point, and you're absolutely right. When looking at the numbers, quite a remarkable length of median follow-up, and certainly again on the survival as well. And we'll speak a little bit more about that. And that gets us to the question of the results. What are some of the things you really would like to highlight about this particular study for our audience?
Yes. Again, thanks for this question, because I mean, people could be confused. So I think that the only conclusion that we can consider from this trial is that if we have this specific population, this was a population enriched, for example, of BRCA mutated patients with a quite long median platinum-free interval. And if you look at the surgical characteristics of these patients, and if you look at the surgical complexity score, it took like a very simple surgery. We had only, I remember, around 14% of surgical complexity score 3. So it was a quite simple surgery. And indeed, these patients had an incredible result. So what we can conclude is that these patients probably do not benefit of HIPEC for sure. This was the main objective of the study. But I can also say that they may achieve an incredible result in terms of outcome. So would you consider not to do surgery in these patients if you have these exceptional results in terms of survival with a very low rate of morbidity? I would say that these are good patients for surgery. So I think this is an ancillary result, although from a very specific population.
Yeah, and I think, again, to your point with regards to the patient population and the patient selection, critically very, very important. So now I wanted to get to some of the questions from our fellows. And the first one's from Elena Rodriguez Gonzalez, and she's from Spain. And she asked, what were the criteria for adjuvant treatment or maintenance therapy after secondary surgery?
Actually, all patients were considered for adjuvant treatment, systemic adjuvant treatment, and they were platinum sensitive, so was platinum-based chemotherapy. Maintenance was left open to each center. And I must say that few of these patients actually received maintenance immediately after the treatment, the main treatment in the protocol. But all these patients received any kind of maintenance later. So there has been like a crossover from one arm to the other, and everybody have received both bevacizumab and PARP inhibitors at the end, but not at the first recurrence, but later on.
Yes. Ali Strubhar from Salt Lake City here in the U.S., she was asking about extraperitoneal only recurrences being included. And she asked, in your opinion, would the exclusion of patients who had extraperitoneal disease recurrences have impacted these results?
Pedro, the point is that actually maybe I was not clear enough in the study, because within the inclusion criteria, we considered patients who had intraperitoneal disease always, with or without extraperitoneal recurrence together. I think that this fellow refers to the results after treatment. So the second recurrence was extraperitoneal in 46 or 47% in each of the arms. So I think that it's a little bit different. But it's interesting because it means that around 50% of these patients will relapse only extraperitoneally. So it's not related to HIPEC, yes or no. It's just about surgery. These patients have been resected completely, and then they will recur in another place, either parenchymal or lymph nodal or whatever. And I think this is the reason they have such a long survival again, because it's not intraperitoneal. So it may affect the long survival that these patients have had.
Interesting. Yeah. Pattern of recurrence in response to subsequent therapy. This question from Raikan Bolatbekova, she's asking more so on the histologic subtype. Mm-hmm. And she says, can we say that the survival results in the HIPEC group were somewhat worse since there are less serous adenocarcinoma in the group compared to non-HIPEC?
So if I remember well, in the forest plot analysis that we did, actually the patients who had no serous adenocarcinoma had the best results with HIPEC with respect to no HIPEC. So one of the hypotheses could be that these patients have, let's say, benefit more from HIPEC, but I counted the number and it's really low. I mean, we have around 10 patients in one arm and 15 patients in the other arm. So, I mean, it's not conclusive at all. I'm not sure we can design a study like this because at the end of the story, 75% of all ovarian cancer are serous. So I don't know if we can ever have this kind of response. And we can't say it's really, it's just, by chance that we have this difference or not. I'm not able to discuss more.
And that brings us to the next question by Susanna Del Frate from Italy, I think also touching on the same point. And she's asking, do you think that there will ever be studies, and I think I know what the answer to this is going to be, that specifically are designed for the use of HIPEC in non-serous histologic subtypes?
I don't think there will be a study like this, but what we can do, and actually there is also a big discussion now in the community of how we can move further, on this topic. What we can do is certainly consider more than the histological subtype, the molecular subtype, which is often associated with a different histological type. So I think if we have to go in a new direction, the new direction would be more molecular than histological only.
Excellent. And Anna, this question is actually about using BRCA as a potentially screening factor as to how to proceed in the decision making. This is from Mina Dages in Turkey. And she's asking, given the high rate of BRCA mutations and their association with better outcomes, should the inclusion of genetic profiling be a standard stratification criteria in future studies evaluating new interventions for ovarian cancer to enhance the reliability of subgroup analysis, particularly in this setting of surgery?
Absolutely, yes. I'm not sure that, the BRCA status only is should be considered, but many others probably, and the HR status is, of course, one of them. And at that time, we had not the possibility of having the HR status, but only the BRCA status. If you look at the results that we have, and this was also a matter of discussion with the fellows together these days, is that actually, we have a very long median secondary progression-free survival, which is not very different in the two groups, in the two arms, although we have a much higher rate of BRCA mutated in the arm of HIPEC. We don't know why. It was just by case. We didn't know, of course. So it seems that it's not really true that BRCA mutation is related always to a longer median progression-free survival. And if you look at the median overall survival, you will see that it's longer in the non-HIPEC group, where we have less mutated patients. So it seems that over the time, the resistance to platinum or whatever increases And therefore, it seems that the BRCA mutation or the HR status is not the only driver for the better outcome at the end of the story. I don't know if it's clear or not, but certainly we need to know the status, absolutely. And we need to know and try to stratify in order to have a more homogeneous population in the two arms.
Excellent. This question comes from Jose Carlos Vilches in Malaga, and he's asking, given the results of other trials such as HIPEC and CHIPOR, do you think that the success of HIPEC could be modified, conditioned by the use of neoadjuvant chemotherapy? Is that a route that we should be exploring further?
Yes, I think so. At least by the data that we have, the positive results are in those patients who received some chemotherapy before surgery and HIPEC. And there is a meta-analysis that was published a couple of years ago that highlights this fact and makes the cutoff at 6 months. So all patients who received chemotherapy within 6 months and then surgery and HIPEC have the best outcome with HIPEC with respect to no HIPEC. So it seems there is a correlation. Now, what is the rationale? It seems that the rationale is that when you do chemotherapy and then you do surgery, you may still have some cells in the tissue around that you cannot see because there is a lot of fibrosis. And so it's difficult to remove all these remaining or remnant tumor cells located in different places. So maybe in this case, HIPEC could help to not to kill the remaining cells. So this is the rationale. Of course, it needs to be confirmed. The second question that may come is that then we should do chemotherapy to everybody and then surgery. But although it's not fair to do, if we compare the results of upfront surgery with respect to chemotherapy in the trials at time of recurrence, the best results come from patients who receive upfront secondary cytoreductive surgery with complete gross resection. So I don't think we should bring everybody right now to chemotherapy and then surgery and then HIPEC, but just those maybe who are not resectable immediately.
Excellent. So, Anna, I think obviously a topic that always comes up when speaking about HIPEC is complications. And it's interesting that there were no differences in terms of complications when comparing the two groups in this study. Do you have any thoughts as to why this would be the case when one would traditionally expect or anticipate higher complications with HIPEC?
Yes. So again, I think we have to consider 2 points. The first one is the rate of complications overall, and the second is the difference between the two arms. The rate of complications overall is quite low. Anyway, I think it's one of the lowest, again, that has ever been presented. And I think it's related, again, to the selection of patients, the simple surgery that we performed, and therefore, of course, the rate of complication is low. Now, the difference, again, we perform HIPEC since a long time, as you can see, more than 10 years, and we have always thought, and we have tried to explain that toxicity is related to surgery, it's not related to HIPEC for 90 or 60 minutes. I mean, except for renal failure. This may happen, but with the thiosulfate, of course, it's much lower or absent. So I think that if you do a little surgery and if you hydrate patients before and after, I mean, today, I feel very comfortable, and the rate of complication, especially the high-grade complications, is really, really low. So I don't see any problem.
Yeah. And then as we come to our set of concluding questions, I wanted to ask you, should there be a need to keep exploring the use of HIPEC in the secondary surgery setting, particularly given such prolonged progression-free survival in the surgery arm alone of this study?
Yes, very important question. And I must say, and I can anticipate that, of course, we don't do HIPEC anymore in this kind of patients. I mean, we had a study which was negative, so there is no reason to offer this approach to these patients. But actually, we are going to consider the results of the cheaper trial. So for those patients who are not in this group, very sensitive, very good, very simple surgery, would we consider the cheaper results? Yes, we are going to consider them. And probably we need another trial. So let's see in the next months what happens.
So, Anna, as we look to this particular study, what are some of the highlights on the limitations that you see for the horse trial?
Yes, if I would go back and do the trial again, I would say that, of course, I would consider the patients who had maintenance, which kind of maintenance, and in which period of time they recurred during the maintenance, either very soon or after the end of maintenance. I would consider all patients for surgery, of course, or any randomization between surgery and whatever, but I would stratify based on what treatment they had at first line. I would stratify based on their molecular factors. Maybe the design, I would not expect such a big difference as I did in the past, but consider that when we designed the study, we had no data about surgery at time of recurrence, and neither the desktop, the GOG 2013 was even presented. So I would consider a difference of 4 months as significant for me, and I think it's really still significant. I think I saw the design of different studies, and for example, the design of the study from the Memorial was very interesting because they considered like a group of patients who had a higher risk of recurrence in order to avoid what happened in my study that took so long time. No? So for example, considering those patients who had less than 24 months of platinum-free interval, not to go too further, or those with a larger, higher tumor burden, just to have more events and not to go so long with the time of the follow-up. So many things to change, yes.
So Anna, I just wanted to conclude with a couple of questions as to like how do we manage patients today? And as you know, obviously there's a lot of excitement about folate receptor alpha targeted antibody drug conjugates. And, some might say, and particularly also now with some data in the platinum-sensitive setting, some might say, well, given these really favorable results with these agents, why just go straight to surgery? Why not just try this first and see how the patient responds? What are your thoughts to that comment?
Yes, I think this could be also an option, but what is the rate of positive patients with folate receptors? As far as I know, it's not very high. And so there is still a big a large rate of patients who cannot benefit from these, at least from this type of ADC. And, the problem is that, of course, we can continue like this for, N lines. But when you go back to surgery, then these patients are really difficult to be operated on, So you may have much more complications. They can be much more frail. They may have much more toxicities related to the previous treatment. So it depends. I mean, you can do everything, but it's a problem of timing. What you want to do first. So in this case, you will select patients that are going to recur after many target treatments and will be not the best candidates for surgery. So I would consider first surgery and then the rest, probably.
Very well. So Anna, I always ask at the end, how does this result impact your practice? So if today a patient with platinum-sensitive recurrent ovarian cancer presents to Gemelli, what is your discussion with that patient as to what the approach will be?
Yes, very important, because actually, again, based on the last guidelines that we have produced, and still because we believe it's worth it, we consider, first of all, secondary cytoreductive surgery. If this is not possible for any reason, we can consider either chemotherapy or also stereotactic body radiotherapy. It depends from the type of recurrence and where the recurrence is located. If the patient goes to chemotherapy, today we reconsider the patient after 6 cycles according to the CHIPEC trial. And if possible, we reconsider surgery with HIPEC because of this.
Excellent. So, Anna, thank you so much for your time. Always enjoy these discussions with you. Always, of course, obviously learn tremendous amount from having these conversations. Congratulations again. Obviously, a long journey for this study. I am sure you're very pleased to have finally concluded the study. I want to congratulate again your co-authors and of course, obviously, make a mention for all those patients who participated in that study as well. So once again, thank you. It's a pleasure. It's an honor.
Thank you, Pedro. Thank you very much. And thanks for remembering the authors and the patients, because still there are patients alive without recurrence. And I think this is the best result that we could have.
Absolutely. Thank you again.
Thank you. Thank you. Bye-bye.